Well, thank you, Jeff. Thank you to the panel inviting me to speak. All right. So I'm going to talk about endoscopic management of acute and chronic gastric or upper GI leaks and fistulas. I'm an assistant professor at UW. All right, so I have no disclosures relevant to this talk. So leak, smart person once said, is a four-letter word, and I imagine that's what I look like on the right there when my resident calls me to tell me the drain has bile or enteric contents in it. But they're an unfortunate complication of all GI surgery. Historically, we've been limited to surgical intervention, right, which resulted in usually disasters, more enterotomies, more fistulas, or percutaneous drainage, or just waiting it out in time, if they could tolerate that. Recent advances, obviously, in endoscopy have expanded our treatment options. You can now clean it, drain it, suck it, bypass it, or close it. I'm going to talk about an overview of the endoscopic management of these acute and chronic GI tract defects using endoscopic clips, suturing, fibrin sealants, double pigtail stents. We can talk about that. Self-expanding stents and endoluminal vac therapy. I'm glad everybody else covered EVAC already because I don't spend too much time on it. All right, so there are two types of leaks, and there's been people have said previously, all right? Acute leaks, the patient is more likely to be sick and have an acute reaction to it, but conversely, interestingly enough, they're more likely to close if you can get to them and treat them early, okay? So in those situations, we can clean it, we can drain it, and we can close it, all right? The reason, characteristics of acute leaks, all right, they typically have limited contamination at that point. They have well-perfused tissue edges. There's minimal fibrosis surrounding the inflammatory process, and there's no epithelialization of that tract, all right? So again, clean it, drain it, close it. Chronic leaks, however, these folks tend to kind of, live out in the community for a while. They're calling your office with repeated fevers, just kind of vague. They just don't fly like you'd expect them to afterwards, all right, because they've got just this chronic soiling, chronic contamination of their surgical bed. And that's unfortunate because when these present later, they've had time to form fibrosis, form a large cavity, have a lot of contamination, and they're unfortunately less likely to close. In those situations, what you want to do is clean it, debride it, and support the healing of the wound as opposed to just outright closing it. They are characterized, as I said, by heavy contamination, necrotic tissues, fibrotic edges, epithelialized tracts, all right? And our game and our play in those situations is a slow and steady kind of approach. Before you can treat a leak, though, you have to find it, okay? And if it's a large hole, that's very easy. If it's a small hole, it's not very easy. If it's a acute leak, it's easier. If it's a chronic leak, it's harder, all right? So you can imagine a large chronic leak. Yeah, I'm sorry, a large acute leak is easy to find. A small chronic leak is very hard to find. So on the left is a large hole, chronic, and on the right there is a very small hole, chronic, found only with some expression of pus from the fistula tract. And these are the tools that we use for that. So a distal cap attachment can use to push the mucosal folds out of the way and interrogate all the different areas of the staple line or the GI tract. A wire to probe and see if I can get that to drop in any space extraluminally. Injection catheters and then fluoroscopy are all key to this. And this is typically how that goes. I'll get the call about a leak. I'll review some preoperative imaging, plan for our endoscopy. Start by inspecting the surgical staple lines or the anastomosis. The most likely spot is where you've done something, all right? So I'll start by interrogating all of that. I'll look for some visible suture foreign body, as well as irregularity or erythema, granulation tissue anywhere in the GI tract. Those are usually signs of inflammation or irritation. I'll look for pus or drainage from the area, and then I'll use fluoroscopy. So in this case, this is an upper GI scope. There we go. Injecting some contrast, we see a little tract going out to a walled-off collection. It's a very typical finding in some of these situations. Once we found it, now what, okay? I'm sorry, title got a little out of order. When we do go with fluoroscopy, we're going to start in dependent locations. Start distal in a sleeve and move proximal. It's because your contrast or anything that you use is going to pool distally, so you want to work backwards up. Inject early with saline if you're unsure, so that the contrast doesn't obscure further fluoroscopic images. And then alternatively, as in this case here, what we did is we injected the extraluminal drain. That yellow line represents the extraluminal drain in there. We injected that. We saw communicate with a large collection up through a little tract, and then that adjacent, oh, missing that arrow. That little spiraginous tract up to the collection superior is the intraluminal collection. So now that we found it, now what? Okay, a couple scenarios to go over, decide what to use, what endoscopic tools to use and when. So scenario one, all right, you got an undrained collection with limited contamination, all right. So this is somebody you've done a sleeve on, you do a post-op day one contrast study because that's your practice, and we see a small little tract extending extraluminally from there, okay. This is post-op day one. There's going to be minimal contamination out there. You're not worried about an inflammatory process, a significant inflammatory process occurring extraluminally. So I would say go in there and close it, all right? And that can be with an over-the-scope clip, suture, or fibrin sealant. I'll go into those in a little bit here, all right? Similarly, a different scenario, okay? This is a couple of days or within a week after surgery, okay? You happen to leave a drain, you go in endoscopically, you find this leak, it's got fresh edges, and you know there's an extraluminal drain to help decompress any infection and contamination, okay? I would argue in those cases, you can also just close it, all right, with one of the methods described or listed, all right? And how do those work? Over-the-scope clips has been discussed. They're great for larger defects, small to larger defects, although they do have a maximum size of about 14 millimeters, okay? To close these, you need to get good tissue apposition, just like we would with any anastomosis that we make. All right, you want to get good tissue to good tissue. So you need to have those tissues mobile. That's why these work better in acute situations, or acute leaks as opposed to chronic leaks, because you need to get those edges together. If that leak is scarred down and you won't be able to mobilize those mucosal edges together, it's not going to close typically with a clip. You want that to be well perfused. And the benefit of the over-the-scope clips is they're largely maneuverable. They fit on the end of your scope you're doing in a forward-facing endoscopy. With those, we get about a 70 to 100% efficacy rate, depending on the study that you read. In all of these, though, early is much better than late approaches to them. Okay, and as I mentioned, fresh tissue edges. So this is that same case I highlighted earlier. The blue outline is the viscous, the air-filled viscous. Our drain in the bottom there. We identified the tract, fired a clip off over it, and what you don't see on that second picture is contrast going back intraluminally on that. Speed up a little bit. There's our clip there. We can endoscopically suture. This works well for larger defects, okay, that aren't going to be covered by the over-scope clips, because it's very hard to fire those sequentially on top of each other in a line, just because of the size of the metal and ability to pull that defect together. So this works well for large defects, again, perfused tissues and mobile edges. Success rates, however, vary on these. It's not going to play. All right, video is not going to play. Depending on which studies you read, again, same as the over-the-scope clips, they're best when treated early. And the problem with the endoscopic suturing is that they get a very bulky platform. They're much better when used on a forward-facing leak. So things up at the GE junction or in the esophagus are hard to make those angles and get good mucosal apposition. You can use a fibrin sealant, so that first case, all right, small leak, small hole, you can inject that into the tract. Works best with smaller defects that are walled off. In some studies, 90 to 100% effective in those situations. Scenario 3, all right, this is a walled off extraluminal collection. You can wash it out and close it just as we had talked about. Alternatively, you can internally drain that collection, all right, with double pigtail stents, plus or minus self-expanding metal stents to occlude the lumen or to direct GI secretions through the lumen, and potentially plus minus distal feeding access. All right, there's our cavity, small serpiginous tract. If we place those double pigtail stents in there, and then a self-expanding stent over the top. What you're working to do is promote drainage by path of least resistance. So the GI tract should be the path of least resistance. If you've got a walled off collection, you just promote that inflammatory process to return back into the GI tract and not promote more going out in there, because again, the path of least resistance is distally in the GI tract. Internal drainage does have reported success rates of 80+% depending on the study you're looking at. But healing is measured in weeks, not days. And residual extraluminal cavities are common after these. Final scenario, this would be a chronic leak characterized by heavy contamination and a walled off collection. These have well-formed tracts and epithelialized edges. All right, you want to perform endoscopic debridement, get any of the foreign body out of there, whether that's surgical foreign body or dietary, because they've been eating and packed this full of food. You want to irrigate, and dilution is a solution. So irrigate all that out. And then your decision on, and then you want to freshen up those mucosal edges. This is an argon photocoagulation. You want to de-epithelialize or take down the mucosa so that you can get good apposition and get that to heal if you're going to close it. You can close it directly. You can internally drain it depending on how large the orifice is, or you can externally drain it with endoluminal vac therapy. These work best with large defects, heavy contamination. It's a slow and steady process, and more proximal is better, but labor intensive. So you're changing these frequently, on average 6+ vac changes, but success rates can exceed 80%. So finally, outcomes, 74 to 85% success rates when identified and treated within 1 month. Predictors of success are earlier, better than later. Small defects, no prior surgeries, no prior interventions. Chronic, again, time is of the essence. You've heard that from multiple speakers. Repeated procedures are often necessary, and they are labor intensive. Sometimes you're just using these as a bridge to definitive surgery. So in conclusion, GI leaks are undesired but unavoidable. Management no longer limited to surgical intervention. Endoscopic management is better tolerated. And the way of new endoscopic therapies demonstrate good outcomes in the management of GI surgical leaks. And then just final points. This list is suggestive but not prescriptive. What tools to use are any and all that we've listed here. You can use them successively. Change your strategy. Don't be afraid to be dynamic. And repeat endoscopy is not a failure. My apologies for going over.
Yeah, no worries. Thank you.